Hi to everyone. Thank you very much for joining today's training capsule on the impact of patient experience unit in children's hospitals. Before we start and we present Joan and Ditte today, we want to give you some indications on how we manage the training sessions. So normally the content is around 45 minutes, including the questions and answers. Just ask Joan and Ditte if they prefer to jump during the discussion or if they prefer to leave the questions for the end. We're going to be recording the session and it's going to be available both in our YouTube channel and on the website. Please make sure that all your microphones are muted during the session. And yeah, we prefer if people turn on their cameras to have a more active participation of the audience. And yes, you can use the chat for any request or question. Also, yeah, thank you, Patri. Make sure that you follow us on our social media and you can subscribe to our YouTube channel. We normally share all the recording content from the i4Kids, so you have everything available on the channel. And yeah, maybe we can. Sorry, Patri. Yeah, and also last thing, we're gonna be celebrating the Pediatric Innovation Day. This is gonna be the next edition here in Barcelona at Cosmocaixa. It will be on the 20th of November. And as always, as a tradition, we're going to be doing it on the Cosmocaixa at the Science Museum from Barcelona. The registration is already open, so you can register your participation both online and in person through the QR code that we are sharing here on the screen. And yeah, thank you now today, Ditte and Joan, for being here today. I think it's best that you can introduce yourselves, and then we will start the discussion, a very interesting discussion today about patient experience roles in pediatric hospital. Maybe we can start with Ditte, please.
Yes, thank you very much for having me. So my name is Ditte. I'm a project manager and my background is in anthropology and qualitative research. And I work in the user experience team in Mary Elizabeth's Hospital in Copenhagen.
Hi, this is Joan speaking, Joan Vinyets. I'm the head of patient experience at Hospital Sant Joan de Déu here in Barcelona. As a background, I'm a designer, anthropologist, and also I have a PhD in social communication. And I'm in charge of all the projects related to understanding patient experience. I'm very happy to be here, of course. Thank you for the invitation.
Thank you, Joan and Ditte. So yeah, before we start with the questions for the discussion, I know you have prepared some slides to provide some an introduction of both hospitals. Maybe we can start with this, and then we will enter with some of the questions we have prepared that we think might be interesting for the audience. So yeah, maybe we can start with Ditte.
Yeah, sounds like a good idea. I'm just gonna share some slides with you, or do you want to share it from yours? What's best? Do you want to share it, Patricia, or should I just share it from my own?
What you prefer. If you like, you can share yourself.
Okay,
I can do it for you.
I just shared from here. It's fine. What's best for you? So it should be there. Do you see it?
Yes.
No? Yes. Okay. Everyone sees the slides.
Yeah, it's not in presentation mode, Ditte. I don't know if you want to try to change it, but we can see it perfectly. I mean, we can see the presentation well.
Oh. Okay. Okay, I'll just give it 1 sec.
Okay.
It is in presentation mode here. Did it change now?
No.
Okay.
But that's fine. Yeah, well, okay. Just try it. And if not, that's fine because we can see quite well. It's quite big, so that's fine.
Okay, okay. I'll just try it here. 1 sec. Better now?
Yes, perfect.
Okay, so As mentioned, my name is Ditte Marie Hansen, and I am from Mary Elizabeth Hospital, which is not yet built. So actually, I'm from Rigshospitalet in Copenhagen, but we're building this new department where we are collecting all the kids and the pregnant women and the young people, which is opening in 27. And that's the project group that I'm organized in. But we also work with the rest of the old hospital. But this is why it's called Mary Elizabeth Hospital. As you see, this is the building that's rising up right now. It's not entirely finished, but the whole building is there. If you visit Copenhagen, you can see it. And it's a public-private partnership between our hospital and our Copenhagen region and the Ole Kirk Foundation, which you know from Lego. And here you see a picture of our old hospital with the different buildings. And you see that all the blue arrows is where we have kids now. And then we want to make this new building and gather all the kids over there and also the pregnant people and the young people. And we don't want to make just a new building. We want to use it as an occasion for building also a new approach and a new culture. Of course, there's also already a really good approach and culture, but it's a good occasion to bring only the best into a new building and leave behind what the healthcare professional thinks should not live on in a new building. So we're trying to still keep a focus on the best possible treatment, but with a human-centered hospital in which we also have well-being and daily life, and we have focus on integrated play and on bringing nature and homeliness into our hospital. And I sit in this user experience team, and here you see a picture of us literally building our office and from some workshops. And you also see some of my colleagues who are in uniform to follow along healthcare professionals to get a better understanding of their everyday life and to see the patients they interact with. We have different competencies and skills within anthropology, service design, play design, product design, architecture, and test design. And we have been, I think we have had our team for 4 years now. This whole building project started out with a seminar of 130 people for 2 days, which was healthcare professionals, clinical specialists, parents, relatives, and kids who were gathered for 2 days to figure out what should this new building project do. But after some time, this was a really good offset, but after some time we could see that in order to really succeed in this project with the play and the human-centered hospital, we needed to have this in-house experience team. So we managed to build this up during a couple of years, and now we're like 14 people, I think. And we work with a test-driven methodology, which is iterative and very classic for design thinking, but it's really good to have in this hospital setting, and I'll show you later some examples of what it has shown us and given to us. We do a lot of test and prototype in the old Rigshospitalet, and also we're lucky enough to have a little test house, which is a 1-to-1 scale from a small piece of the new building, and there we can try out stuff and try to build it 1-to-1. So this is a picture of the staff, and it's because we think that it's very important that we're not actually... Anyone wanted to ask something? No. We're not actually a patient experience team, we're a user experience team. And this is because a big part of our users is staff. Sometimes we cynically say that kids who are awake and who want to play is 3% of our users. So we shouldn't design only for them. What's really important is that we design a hospital in which it makes sense to go to work, and we don't disrupt a good workflow, but we help a good workflow. And we help the staff to have a day in which they also get help and energy to be there for the kids and the families, because this is what will make a good hospital at the end. So not only a good experience for patients and families, but also people who are there night and day, literally. Here you see some of the things, some of the main concepts that we're working on for the new hospital. So it consists of safe arrival and farewell, of warm hosting, of digital guidance, valuable waiting time, a playful approach, meaningful spaces, art experience, and a homeliness atmosphere. If you want to, I don't have time right now to go more into the specific concepts, but we have a homepage that I can share with you afterwards if you want to dive into some of these concepts and see what we're working on. And now I'm just going to briefly go through some examples. I know already that I don't have time to explain it all, but then afterwards in the discussion, if I mention something, then at least you have a picture in your head of what I'm talking about. And this is just to show you that it's a very broad variety of what we're working with, from digital service to building, to rooms, to services, to food. So it's very diverse what kind of concepts we work on. Here you can see the test house that I mentioned. It's 1-to-1 scale. And we've had lots of clinicians and families over there for the past couple of years to try out prototypes. And it's just shown to be so much easier to imagine and try out something if you're in something that is very close to the real building. It can be difficult if it's just made out by cardboard in the old building. Of course, you can also use that, but this has been really, really valuable for us. For example, here you see a visualization on the left-hand side and the real test house in the right-hand side, where you can see our first take on our bedroom in the hospital. Then we took families in and tried to test it. You see, for example, a small table, which showed out to be very crowded for the families, and you see a bed coming out of the wall for relatives. This wasn't good. People were afraid that bed would burst and the table was too small. So trying this out was really good instead of building 180 rooms like this. So here you see visualization of room number 2 with a bigger table, makes room for family time and cardboard games and a real family dinner, and a different kind of bed that people are more comfortable with. And we have, I think now we're on iteration 3 or 4 of the bedroom. So we've used that a lot. Oh. And here you see something from our playful approach, some of the elements. In the top left, we have our, what we call our ground rhythm, which is a rhythm we teach everyone who works at the hospital. This is how we meet the families and how we meet each other. You have in the left corner our planning boards, in which you can use magnets on a whiteboard to talk to the family or the kid about the plan for today or the plan for the intervention. You have our tool belt, which is ways of interacting with the family, ways of getting them to collaborate with you. And on the right, you also have a picture from Epic, the computer system, in which we made a site called the side of the child, where clinicians and healthcare professionals can share knowledge about the kid that is not directly related to the illness they have. So for example, this kid loves basket, or this kid loves to sit on their mom's lap while having a blood pressure taking, which was really difficult for people to share in a way that was easy to find. So we made this with Epic a new way you can write it directly to your colleagues. This is a stillborn delivery room in the old hospital, in which we tried to implement our design principles when we renovated it, to try them out. Here is a waiting room where we tried to make some ears that would prepare the kids for having their ears examined. And here you can see some visualizations of how we're going to work with the wayfinding and how we work with making spaces It can be a staff lounge room. It can be a play, what is it called? A play space, or a reflection room, to create something that breaks a little bit with the institutional look of a normal hospital. And the last example is a dialogue tool, dialogue box that we made for liver transplantation, in which there's a lot of elements from everyday life that the clinicians use sort of as a checklist to have a conversation with the families about what life is like after having a liver transplant. So these were just some examples to show you what we work on. And I think my time is up, so I better give the word to Joan, but I'm looking forward to discuss more with you afterwards.
Thank you very much, Ditte. It has been awesome to see how everything you're working on from Copenhagen. So if you are okay, Joan, we can start with your presentation, and then we just will have this chat and open the mic as well to our audience just to see what are the questions. Joan, would you prefer me to share the presentation?
Yes, please.
Or
Yeah.
See? Okay.
Yeah. Yeah, thank you so much. And thank you, Ditte. As you can see, it's very impressive, the work that they are doing in Denmark. I was so lucky to be there in November. So it's really fantastic, all the project that they've been dealing with. And I'm sure it will be amazing as experience for parents and children. So my presentation, I'm sorry, it's no awesome as Ditte. But I try to divide in 3 parts, and this is the main hall of our hospital. This is a big difference. We already have a built-it hospital. So here you can see this is the main hall, and then I will give you first a little bit of context, so we can go to the next slide. And here you can see some facts about the hospital. This is the activity from last year, and you can see the discharge, the emergencies, the consultations, and the surgeries that we had last year. I'm sorry, because in terms of deliveries, the data is from 2 years ago. And in our case also, we are a specialized care center for children and pregnant women. And then in terms of beds, you can see that we have 377 beds, and more than 100 are for critical care. And currently, this is the information about the professionals involved at the hospital. It's more than 3,000. And if I'm not wrong, physicians will be around 600 physicians on the total of this number. So in the next slide, you can see our expertise. We are a tertiary hospital. So we, in the last years, the hospital had been moving more to become more very specialized in rare disease and minority disease. And here you can see the different areas of expertise and also all the different accreditations coming from international level, national level, and also regional level. And also to give you an idea of the hospital, here you can see some of the pictures of these different spaces that we have at the hospital. And in the next slide, I think, I wanted to share this because I think if we have to discuss about patient experience and innovation, it's very important that knowing where we come from. And we are part of a humanitarian values-driven organization. And one of the main values for us is hospitality. So, and this is this idea about, having this capacity to welcome and support people in order to meet their needs, placing them at the center of our attention. So then you can understand that patient experience plays a big role because it's part of this, making possible this idea of hospitality, this supreme value. So in the next slide, it's more about the way, we want to put in place this value about hospitality. So we understand patient experience as a complementary view of the biomedical approach. So we know that the patients come here because they want to be, in good hands with the best experts, but this is not enough. So in our case, we provide this complementary vision at the biomedical approach. So as you can see in the next slide, our focus is about trying to provide the best experience for patients and families. And this means trying to cover all the journey of our patients when they enter the first time at the hospital, when they go for a surgery, when they are waiting for an intervention. This is the type of work that we do. So in the next slide, at the end, if you think a little bit, what's the role of patient experience? It's about trying to promote this person-centered care, which it means putting at the center patients, family, and professionals, applying this patient experience approach. I always like to say that, we are the other lens that we can bring to the professionals of the hospital. So in the next slide, this is kind of the basic tool that we always use to develop our work. And it's the idea that we develop always these patient journeys. And as you can see on this image, the idea is that we try to focus on the red dot points, so in the critical points, in the pain points. And our work at the end is always how we transform this pain point in value, in opportunity to provide value. So in opportunity to improve the care we deliver, or to innovate the way to deliver this care. So then to do that, we can go to the next slide. We have also a team, and here currently the patient experience team is 6 professionals with different backgrounds. But I think what's important, and you can see on the slide, is the different knowledge and expertise that we bring, that it's very complementary. And as you can see, it goes from anthropology, design, engineering, etc. So this is the team in charge of patient experience. And we develop different types of projects. We can go to the next slide. And at the end, because there is no time, and because it's more important to have discussion, here you can see basically, of course, I will not explain all the projects. This is for you kind of a snapshot of the type of projects we do. Normally, we develop between 20, 25 projects per year. And here you can see basically a lot of projects are very strategic and are related about, healthcare facilities, spaces, and environments. The same type of work as Ditte been showing before. And then if we go to the next slide, the projects are more related not only at spaces or buildings, but also about how we can develop or innovate new models and services to deliver care. And so this means that sometimes it's about training, education, information, and to do that we collaborate with different departments and units, with the healthcare school here, or with the infrastructures team, or with the information team, etc. But I think we will discuss about that later. And last slide, I think it's important because at the end, patient experience is not about us. It's not about having a professional team. It's about all the professionals that we work at the hospital, because at the end, all the professionals are the ones delivering the patient experience. So it's a work that should be done for from all the employees at the hospital. And this was the last slide, so open for the discussion. Thank you.
Thank you very much, Ditte and Joan. It has been really interesting just to have this overview of what are both hospitals working on. You have some similar points, so it's good to see how you're working in the same subject, but with a similar focus. So if you like, I just can start with one question. It's so if you can just tell us a little bit about where the patient experience team sits within the organization of the hospitals. In other words, how is your team positioned inside the institution? So Joan, please.
Yeah, well, in our case, there is a department It's called the Department of Quality and Patient Experience. And this is important because patient experience it's completely related about quality. This is the way, as the hospital understands the role of patient experience. So we are sitting in this department, quality and patient experience.
So Ditte, please.
Yeah, my team actually has just recently split into two. So the old part of the team is in the building project. They're still making ready for this new building, and they're designing the rooms, finishing and putting it out in the market, making like the procurement. And then we are like 3-4 people who has made a little PLAYLAB, which is in the test house very close to the old building. And the idea is that we're more like maintenance. We're like for everyone to come down with an idea and we can make some new innovation or something, but it's more for everyone in the whole building, not just for the new building. So we're situated 2 places. And within the structure, the building project it's its own structure, and we as the PLAYLAB are part of maintenance value in it's called the value department, so like quality in the old Rigshospital.
I will just remember to all the attendees that we are so happy just to, if you can join us in this conversation. I think that Ditte and Joan will be happy also to answer any question that you may have. You can just use your microphone or just the chat, and we will be just so you can join this conversation. But meanwhile, we have some questions from the audience. We have been working in. Oh, Mary Che, please go ahead.
No, but really, thanks. I'm Mary from the brain.
Really Mariche, sorry, we have some problem. Yes, we have some problem, I think, with the audio. I don't know, maybe you just can chat, because I wasn't able just to hear you properly. So Che, if you like, we can move to Paulina. She has another question too. Paulina, nice to see you again. And so Che, you can just see if the connection improves, or you can just write on a chat, and that will be perfect. So Paulina, please go ahead.
Hi, my name is Paulina. I'm currently working in London at Rejón Street, and a lot of my research is how children experience the hospital and how they interact with play. And at the moment, I'm researching how children with autism and learning disabilities experience hospitalization and experience cancer care. And the question that I'm familiar with the work that you both do, and I've been there, and I really always admire both teams. But I was wanting to ask, in all these creation, co-production, and design, how do you integrate children with autism and learning disabilities into the designs? I'm very curious into what part of that process is aimed for this population. Thank you.
Yeah. Well, for example, I can mention, a project in which now we are working. In 1 year and a half, our hospital will be opening a new building, and we started to work on try to define the design requirements based on the patient needs. And this building will be for all rare disease. So in our case, what we did, it was during all the research stage, we were interacting with families, with kids that they have, the conditions that you were mentioning. So, and of course, this didn't mean that we had to adapt the way to interact with them. Even sometimes ask, help from other professionals, from the hospital, or even from their parents. So in our case, it was clear that we needed to integrate in our research sample these profiles of patients. And then based on that, we've been providing the specifications at the infrastructure team, and that then they are working with the architects. And even, for example, now we have several projects, for example, related to these specific groups of patients that they have specific needs, with let's say, the autism spectrum or other types. So now we are starting to develop specific projects. But the idea in these projects, for example, now we are working in one about information and communication, how we can prepare these patients before certain treatments. So we are starting a project on that, but the idea will be to try to develop a solution that it's inclusive. So it means, our idea is to try to work in a solution that it works for all type of patients, because I think one of the problems I always see is stigma. The stigma that sometimes you create a solution that it looks only for these patients. No? So this is the kind of way in which we are working. So Ditte, please.
Yeah, I agree with you, and we do it very similar. We try also to say that the benchmark is an 8-year-old, but it should work for everyone. So, for example, with our planning boards, with the magnets, you also see that in institutions for kids who have disabilities or autism. So, and the fear for some people was that it would be too childish or too simple. But what we see is that it's actually very good to design for simple and childish, not childish, but human simple, because if it works for a kid with autism or a kid in crisis, it also works for the parents, because everyone is in a crisis. So there is an IQ drop for everyone. So it's good to just use kids with disabilities or problems as a benchmark. We have like a user bank of people who signed themselves up to be part of our test or interviews. And we know there is a problem that the people who sign up are people who have resources. So we try also to go home to people, like offer to come on a home visit for interviews and stuff like this, because maybe people with who have less resources in some way, it's more difficult for them to participate in this kind of thing. But it is always challenging to get the people who have most difficulties to engage in these kind of design processes. So it is something we need to be have our focus on.
Thank you. Okay, so we have one question at the chat as well. So let me see, Elizabeth just said that she is already a fan of Danish design, Ditte, but now even more. So she's very impressed with all how site staff and patients and parents have been involved in the development. So she is asking, which age do you have children in this new hospital? And I'm asking because adolescents may have different needs than younger children. So I think that that's an interesting point, just to see how, because it's like from newborn to adolescents, or maybe that's a challenge, just to have like this user experience to adapt to these ages. So please, Ditte, and then Joan.
Thank you very much, Elizabeth. Well, actually, a little bit as I just mentioned now, we say that we just make a human hospital. We don't really make a kids hospital. We have in the new hospital, there's going to be all ages, because we have from newborn to pregnant women, and yeah, from 0 to 18. So basically our group is everyone. So we have some design principles that we like to make it possible for people to interact. They should know what they can and cannot do. They should have possibilities of doing something and engage with the hospital and participate. It should be clear for them what the plan is. It should be playful, but not childish. And we believe that actually playfulness is also for adults. So we don't make Disney World all over, but we take these basic elements of like sleeping well, having space for the whole family, making it homely, making it safe, making it actionable. And all these principles are human principles. They're not kids' principles. So I hope that was kind of an answer. We hope that this is just that the new children's hospital is just where we try all these principles out, and then eventually they will roll out to the rest of the hospital, or hopefully other hospitals in Denmark, that it's just human principles.
Joan, please, how do you solve this challenge at Sant Joan de Déu?
Well, I think at the end, you know, it's kind of it's the same approach. It's this idea that, for example, as Ditte was mentioning, no, neither in Mary Elizabeth or in our case, you see Disney, you know, these characters or you know, as ambience. So it's the idea to try to find certain types of elements that they can be kind of universal, that could be interesting for you know for children, but even for adolescents or young adults. But said that, for example, we know that beyond the environment and the spaces, it's true that this segment, these adolescents and young adults, they need other way. So, for example, in our case now, we started 1 year ago a new model. We are refining the new model for how we can deliver care for adolescents. And it's more in terms of the way to communicate, the way to interact. And we're working on that because we realize that you can't approach as a physician or nurse on the same way, you know, a children 5, 6 years old versus a patient that have 14 or 15 years. So on that, I will say that there is a big difference. But then in terms of environment and space, I think as Ditte was mentioning, if you try to have this kind of universal approach and these universal elements, that's the way.
So, Mary-Chey, I don't know if I would just read. So did you track the difference on feedback of international patients in the patient experience programs? Needs could be very different. So, Joan, what can we say about this?
Yeah, well, here at the Hospital Sant Joan de Déu, we have international patients. And for example, in our case, yes, this is something that we do. And for example, in these last years, we've been developing different projects to try to understand different communities, you know, patients and families coming from different regions of Europe or Asia, and then, you know, sharing this knowledge with internally at the hospital, because these have implications in the way in which you will communicate, in the way in which you will interact, in the type of information that you will provide, and also, you know, in the treatment, because we know, for example, it's the case, no, that with the Muslim community, we have a lot of patients from there. You can approach the same. There are certain aspects related to the privacy, and especially when you are dealing with women. So these kind of things, of course, it's something that we take on into consideration when we think about you know the patient experience.
Yeah, the same. We also try to think about it as with the disabilities and everything. It's a very diverse group. For example, with our reflection room instead of a church, and just in general with different cultures, what people would like for a bedroom, for example. And then we have also put it in our user bank, like to be aware of people, where they are from, and try to call in different kind of families when we have a test or so. Yeah, but we made a very big work the first couple of years before starting to build, where we tried to ask and engage with as many different users as possible. But this will also be often a blind spot, which is difficult to cover. But yeah, we try to work on it as best as we can.
Sure. So just before moving to Lynn's question, I'm also thinking about these needs. So how do you identify these needs? Because I'm talking about then how innovation, you know, interacts with your department. So you have in your presentations, you have shown us that how you like this process, but I would like you to be a little bit more concrete about how do you work and how do you identify these needs. For example, do you get them from the staff or do you get them from, I don't know, surveys? How do you do this process of identifying needs? Joan, please.
Basically, there are different ways, about gathering data or the voice of the patients. You have the systematic kind of voice of patient, questionnaires. Every time that there is a transaction, they will get a questionnaire, and so they can also provide open feedback. That's a way, but then the best way is always through doing field work with them, understanding, starting projects specifically to address some kind of challenges, and then being with them. So it means spending a day with them once they are at the hospital, or even when they are, if we are delivering care at their homes, being there and talking with them. So on that, I would say that, Ditte, also she's an anthropologist, is about being an anthropologist. It's doing field work and understanding, because so many times people, if you ask what's the pain, they will not know exactly what to say. So then the best is to be there in the context, and while observing how they are doing things, probably you will realize that there is a lot of latent needs that are difficult to express, but you can identify. And then I will say that you use a combination of different tools, because even sometimes it's not enough doing the field work. So then probably we'll have to to set up a kind of a workshop or a session in which probably will provide some prompts that will make more easy for them to talk. It depends a lot. It's with with different methods and tools, very very qualitative. Of course, sometimes even with quantitative to validate these insights. And then the relation with innovation. Well, in our case, I have to say you are fantastic, Patricia, Sofia, and Arnau. We are so lucky that we have the innovation team, and there is a direct contact. So it's very easy. When you need, you call them, you can share insights, and it's really amazing that, with all the initiatives that you developed, with all the challenges, and, so many times you are the ones providing some insights to them. So I will say in our case, it's very natural and very easy.
The same anthropology, mixed methods. So I'm not going to elaborate on that, but what I can say is that this is also why I think it's really, really good to have an in-house user experience team, because then we gather experience and we really get to know this group well. I've worked with hospitalized kids in 10 years now, so some of it I just know because I talk to so many families now, and I've tried to be in the outpatient clinic with them, and I've walked around with them for days. Whereas if every time we had a new project, made a little pitch and send it out to some office in the city, they would every time have to gather a new understanding of what is a hospital and what is important when you're in the hospital. So I think also having a team, building up experience, and being able to have this very close collaboration with healthcare professionals, because if it's an office out in the city or like a bureau, they won't be able to talk to clinicians all the time. My office is right in the hospital, so if I'm in doubt, I just run up to my nurse or my doctor and I say, hey, is this actually a problem? Have you seen this a lot? Or should I talk to a family about this? And I think that makes it a lot more site-specific and a lot more context-specific than if it was externally designed.
So let's go to the chat again. So we have Lynn for Oslo University Hospital. So how do you measure and assess whether the initiatives you implement actually lead to better patient and family experiences? So Ditte, please.
Yeah. So some of it, like the bigger strategic thing that we do in the new building, we have a consultancy bureau that are going to measure it because it's a part of the deal in a public-private partnership with the Lego Foundation. So we have, I think it's Implement or some big consultancy company that has made a baseline some years ago talking to lots of families and clinicians, and then they're going to do, and sending out schedules and stuff, and then they're going to do the same after opening. But on a day-to-day basis, we also use our anthropological methods mixed with some counting. Like if we make a dialogue tool, we go and observe maybe 20 conversations, and we count how many times did the kid point, how many questions did they ask, and we give them a before and after test, like now do they know these 3 important things about liver or what we're working on. So it's also these mixed methods. Maybe we send out a schedule and ask them to put some crosses, but in our day-to-day small prototyping, it's smaller. And on the big strategic things, we have a company measuring us, because we shouldn't measure our own things in that way.
So yeah, to add on that, I would say, you know, we have more or less the same approach, but basically it depends always about the, you know, what you want to evaluate. And then normally we combine. Sometimes, you know, through this patient feedback questionnaire, you can address specific questions regarding the change that you did or the innovation that you provide. But then also we use prems and prompts, patient experience reported measures, and also, you know, in terms of prompts. So we are working on different tools and methods to assess that. But I would say, you know, that at the end, the most effective way, it's once you have a conversation, and when in a very open way, because even, you know, always there could be some kind of biases when you ask questions, but if you are in an open conversation, it's the best. And that's one of the biggest problems, that we try to make quantitative something that is very qualitative. And I think that's a big challenge that in the health sector there is, no, that we try to do all quantitative, but at the end, you know, the best way, let me share you know, an anecdote. The other day I was walking on the main hall, and there was a mother with a patient. The patient, she was probably 9, and she was running around the main hall, and she was saying, "Mama, mama, here I won't be here, but I don't want to go to the hospital." And she was already at the hospital. So that's amazing. That's the best impact, you know. And how we measure? Well, because I was there listening, because at the end it's spontaneous. But of course I know it's difficult. So then you have to rely, as Ditte was mentioning, in different methods.
Thank you very much. We just have like well, we have overpassed the 45 minutes. I don't know if we have any other questions from the audience, or maybe I would like just to finish as well. If you have to highlight the main challenges that you have now as a unit from to the future, what would you just highlight? So what are what we should be focused on in users experience and patient experience during the following 5 years, maybe? Don't know. Joan, please, what do you think?
Well, I see, for me, I don't know, but I feel like for me one of the big challenges is the role of technology, because I feel like sometimes we are so excited about technology, and it looks like technology will change the world, will make healthcare completely different, and it will be, and of course, yes, I agree in certain aspects, but I think we have to be careful on that. For me, this is one of the biggest challenge, you know, how to find the right balance, you know, because one thing is what is technological possible, and the other is what's culturally acceptable. And I think on that, you know, this is, for me, it's a big challenge. And then, and I see, at least I've seen before that it was one of the physicians that she's in charge of that at our hospital. So I will take advantage to put in value her work. I think also, for me, one of the big challenges is how we could provide emotional support to patients and families. So when I look at all the challenges we have, I think that, you know, patients and families in these vulnerable situations, one of the biggest challenges is how we could provide more emotional support. And I think this is a very also important challenge for innovation.
I can't hear if there's a question.
Yeah, sorry. So if you just can highlight.
No, sorry. I
sorry.
just thought someone else was asking a new question. No, okay,
No,
maybe
no,
it was
no.
just mumbling. No, I very much agree with you, Joan, especially on the technology thing. Going in at like finding a right balance, because right now it's all about what can we solve with technology and how can we optimize it for cleaning and hygiene. And I think, as in the rest of innovation, actually, coming a little bit back to all this analog and tactility. And I know these are wrong words in a hospital, but we need to find this balance, because this is also what makes it human. If it just becomes like this very smooth machine, it doesn't really rhyme with human. So exactly what you said, finding that balance. And that's also about the emotional support, like not feeling that you're in an institution, but feeling that you're in a place that sees you and recognize you. These has been, like, recognition has been a big side effect of some of the things that we did, actually just to make the intervention go smoother. But all the families say like, oh, just that you made an effort to try to do this differently, we feel more seen. We feel more seen as human, that that you try to explain this with things instead of just talking. So that's a big side effect that I think we could really scale up, if it makes sense.
Thank you, of course. Thank you. Thank you very much, Ditte and Joan, and to everybody that has joined us. I don't know if you would like just to say something just to before we finish this training capsule. I'm so happy just to have been able to share this time with you, and talking about impact, and talking about emotions, and talking about how we make things easier to patients and families, and to users as well. I mean, the staff of the hospital is also important, just to be focused on in the middle of on this attention. So I don't know, Ditte and Joan, if you would like to add anything else, and otherwise we just say goodbye to everybody, and just Joan, Ditte.
I would just say that some of you wrote in the chat, like, can we talk more about this or that? And please do so. You can just reach out. And yeah, we have a homepage, but we're also really curious to get some network and talk to other people about their good ideas or experiences. So glad to meet all of you.
Well, yeah, the same for us, but I would like to add something, that at the end, you know, we can talk a lot about patient experience, about innovation, but I think the most important factor to make all of this happen is about leadership and the culture of organization. If there is not the right leadership, the right mindset, you know, the right culture, nothing will happen. And I feel like on that, and I'm sorry, Ditte, because maybe I'm talking on behalf of you, but I think we've been so lucky. We are in two organizations that, you know, they have this type of culture that make possible that we do our work every day.
So thank you very much. Of course, if someone wants that contact of Joan and Ditte, and if they allow me to do, I can just share with you, and yes, Paulina. And so thank you very much for this session, and hope to meet you again. I think it has been so interesting, and thank you very much for joining us to this Cycle-Kids training capsule. Thank you, Ditte and Joan. See you, everybody, in the next time.
Thank you.
Bye.
Bye.
Bye. Bye. Bye.